Alrighty, good afternoon, everybody. It's 12:01, so we're going to go ahead and get started. My name is Grace Dennis, and I'm so happy to welcome you to the 7th Annual Cannabis in Practice webinar series hosted by the Washtenaw County Health Department and the Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for the series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. To review some housekeeping notes, all participants will be muted throughout the session. Please use the Q&A box to submit questions, which will be answered at the end of the presentation. If you require a live transcription, select the Show Captions function, and if you don't see it, please resize your window to be wider. This webinar is being recorded. The webinar recording and the presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. This live webinar has been approved for 1 credit hour of social work continuing education, McBath credit, CHES credit, Mishwa credit, and CME credit. If you are requesting any of these continuing education credits, please be sure to stay until the end of the webinar to fill out our post-webinar evaluation survey. None of the planners or speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. And now I'm pleased to introduce today's speaker, Dr. Brittany Tayler. Dr. Brittany Tayler is a double-boarded internist and pediatrician based in Flint, Michigan, where she practices primary care and serves as the assistant professor at Michigan State University's Department of Public Health. Her clinical and academic work focuses on the intersection of addiction, policy, and health equity, with a particular emphasis on youth substance use. Dr. Tayler regularly speaks on emerging public health issues, including tobacco, e-cigarettes, and cannabis, and is actively involved in physician advocacy efforts in both the state and national level. Dr. Tayler, thank you so much for being with us here today. I will now pass it on to you.
Hello, everybody. Thank you so much for coming today. And I'm super excited to do this presentation for you all today. Let me just put it in presenter view. So I have a ton of information that I'm going to be covering today. And so I'm going to be on time and leave time for questions, no matter what. So if I don't get to absolutely everything on my slides, or you feel like I might maybe went a little fast on my slides, you'll have the slides after. I wanted to make sure that they would be a really great resource, so you could use them after as well. So I'm really hoping to give like a very nice overview of lots of different things that you might talk about and need to know when you're seeing someone clinically, or even just in a different setting, even if you're not working clinically. I think it could be helpful in many different things, especially in public health. So I don't have any disclosures, as they stated too. So these are the learning objectives. I know that they've already been sent out, but so lots of different things that we're going to try and cover today. A lot of it's focused on just kind of knowing about cannabis and how it's sold and how it's consumed, and then a little bit about kind of the health impacts, as well as the endocannabinoid system as well. So I always want to preface at the beginning that this is pretty up to date. I just got this in April. I don't believe there's been any big changes, but marijuana and cannabis, which I'll use those two terms kind of interchangeably during this talk, continues to become legal in states, whether medical or recreational. And so I want to point out Michigan has had legal cannabis, both medical and recreational, since the tail end of 2018. So we're going on more than 5 years that we've had legal cannabis here. And I always want to point out too that that Wisconsin and Indiana have neither medical or recreational, and so those two areas have had different issues and concerns around cannabis, and so and that continues to kind of change and grow throughout this over the years, and I think it will be continuing to be a rapid thing to follow. Another thing that I want to point out is some of the trends, and this is just from the Monitoring the Future survey about the cannabis use in adolescence over kind of a very big swath of time. So the amount of cannabis that's been used has kind of ebbed and flowed depending on when you were in a point of time and what kind of public policies were going on, what sort of views there were around cannabis. And so you can see back in 1990 and then kind of rising until the 2000s, we had kind of an increase in the amount of cannabis that was being used by adolescents, and specifically in Michigan. And then we had a dip following that. A lot of that's contributed to a lot of policy and different educational campaigns during that time. And then as you can see that kind of starting in 2019, we started to have an increase again in the number of the amount of cannabis being used by adolescents. And we had a little dip during 2020, which makes sense. For most substances, it was a kind of a period where adolescents were at home, and so they weren't out and using substances quite as easily. And then we've kind of returned to pre-pandemic levels around this. You can also see that the older an individual is, the more likely they have that they have used cannabis as well. And then kind of lastly, and why I'm here and why I give talks about this, this is a study that was done a couple years ago, which showed, which was discussing medical students and how comfortable they felt discussing the harms and the benefits of cannabis, and if they had received any training at all on this. And as you can see, most of them had not received any. 60% said they hadn't gotten any training about this, and 38, almost 40% said they only had a little bit. And most did not feel prepared or only felt slightly prepared to talk about this. And so obviously this is just medical students, and this was a couple of years back, but this has still been a big issue. And so that's why I'm here today talking, and that's why I give a lot of talks around this, because I feel like this is a super, super important thing to be able to discuss with patients and clients in the community. It is one of the most commonly used substances, more than tobacco, and that's a thing I love talking about, and we all know the health harms about that, and all are able to converse about that. So I think it's super important that we continue to educate ourselves in this. So I kind of frame the discussion a little bit about if you were in the clinic or you were talking with an adolescent, just to kind of think about some of the different questions that you might want to ask, and things I'm sure that have come up in your interactions with folks. So kind of setting the stage, it's a 17-year-old male who recently moved from Ohio to Michigan, so from a legal state to a legal state, and has a history of anxiety and some back pain, and has noted that since he's moved, has had worsening of some of his symptoms. He does use cannabis, and recently actually increased his use to combat these symptoms. So usually I'm in person, so I apologize because some of these are like answer in there, but think to yourself what kind of things that you might want to know about his cannabis use. Maybe these are questions that you already ask and you already are kind of routinely doing in your practice. And so some of the big things that I'm always very, very curious about, and this is the things I ask my residents to ask about, and I ask my medical students to ask about, and I'm hoping that we'll cover a lot of these topics so you feel more informed when somebody answers these questions, what that means. So a big thing is patterns of use, how often they're using, how the route that they're taking, if they know the dose that they're taking, if they know the difference between their THC and CBD, the strain. I feel like this has kind of fallen a little bit out of favor. A lot of times people would talk about sativa and indica, and I still think that is something that people will talk about, but not to the same extent as a couple years back. The source is super, super important. Again, we're in a legal, recreational medical state. So that means that most people are getting it from a dispensary. However, in those under the age of 21, this might be a not as reputable source. And so it's really important to know where they're getting this, because this can be contaminated or laced or may not even be cannabis. So that's a big thing. Another thing that's huge is why they're using. So there's tons and tons of different reasons that people use cannabis, from symptom management to just enjoyment. And when you're talking to somebody about it, it's really important to keep that in mind. Another thing that I always get into, and we'll talk about this in a little bit, is the impacts on functioning, particularly with school, with adolescents, is impact on schoolwork, asking about withdrawal symptoms, different things like that. And then another thing is safety behaviors, including driving or driving with others, sexual activity, etc. Another big thing to help frame the discussion is the status of peers, friends, family. It's a lot different discussion that I'll have with a 17-year-old if both of his parents use cannabis, as opposed to someone who doesn't have anyone else who's doing that around them. And And the co-use of other substances is really important, especially when talking about impacts on functioning as well as safety behaviors, because there's a ton of co-use with tobacco and alcohol and other substances. And so it's important to kind of get a full sense of what else is going on. So one of the things that you may or may not use, there's quite a few different screeners, especially in adolescents, that can kind of look into the amount of cannabis or marijuana someone is using and see if that's potentially problematic. But the one that I love using is the Craft, just because it has an A and a B. So in the A, you just ask straight up if they've used it all basically in the past 12 months. So if it's 0, then you don't have to kind of go into all of the other questions. And I like that they pull out marijuana specifically, and they also use the word synthetic marijuana and vaping. Excuse me. Um, sorry. And then pull out other drugs, because a lot of times if we combine cannabis and marijuana with illegal drugs or different things like that, people may feel a certain way, or if you didn't specify it, people may not pull that out, because everyone has a very different concept of what a drug is, etc. And so that's super important. I also like the other questions that they ask about in terms of for the car. So again, kind of the safety behaviors, if they're using to relax, if they're using them when they're alone, and other kind of impacts with that. So talk kind of a lot of the things that I was just mentioning. If I'm not, like, say I get into a conversation with a youth and I haven't had the Craft or something like that, but I do want to ask about cannabis, is that I usually will do my 4 Ps, and I try and use very normalizing kind of statements with this. And so what I do is I slowly get closer to their own personal use. So I start with past use, which is kind of the furthest away and the least threatening, parental use, peer use, and then their own use. So I can slowly kind of get closer to the question I really want to ask, but kind of open up the conversation. And I feel like that can be really helpful as well. So this is a super busy slide, and I'm really sorry, but I really wanted this on like one thing, so that way you could come back to this later and look at this. And I will say that this isn't necessarily, this is probably something that will change. I feel like I update this every 6 months, because this is a big kind of changing thing, is what cannabis products are out there, what are they commonly being used, what are the other names for it, and what are the concerns. And so I'm going to kind of highlight some of them here, just to kind of give you a little bit of awareness. And again, I wanted this all in one place. So I think the one that we most commonly think of is smoking. So that's joints, blunts, spliffs, pipes, bongs, chillums, all sorts of things. It's the most common way to consume cannabis. Sometimes it also contains tobacco products, as often the paper wrap is actually made out of a tobacco leaf. It's a very fast onset, but it's much easier to control how much that you consume with it, because of how fast it is and how short the breathing and everything is with that. There's a lot of notable health concerns, particularly around smoking. We know that smoking anything is probably bad for your lungs and your heart, and has that kind of traditional strong odor that you think of. Vaping kind of dovetails into this and has kind of waxed and waned in popularity, and so that can be with vape pens or cartridges. It's usually more discreet, does sometimes still have an odor to it, and does have a lot of perceived safety. There can be kind of a mixture between THC and CBD, so you're not just smoking the whole plant. There's also something that's a little bit less popular, which is called a dry herb vaporizer. So that's where they put the actual full plant, but they don't combust, so they don't set it on fire, and that's kind of thought to be more safe by the general public. Concentrates are kind of go off of that as well. It's typically dabbing. I always want to point out that dabbing is very complicated. It's a very intense setup. You're basically flash vaporizing something. So a lot of youth are not doing that just because it's very intense and can be very dangerous. And there's a lot of different concentrates that you can put on it. So there's all these different names: wax, butter, shatter, crumble, that come up, and it really has to do with kind of the consistency and how it looks, the clarity of the product. The THC, these are the ones that often are super, again, they're concentrated, so they can be as high as 100%, where the whole thing is just straight THC. Typically, it's around 40 to 80% here in Michigan. I think the second one that we think about the most behind smoking is edibles. So this can be a variety of different things. I always want to point out that drinks are a big thing that's been kind of coming up that either has CBD or THC in it. And it has very long lasting effects because of the way that it's consumed. The dosage is very specific typically on these, but it's much easier to overconsume because of a very long half-life and how long it takes to actually kick in. A big thing I also want to point out is that people may have differential impacts of this depending on what else they eat with it. They really needs butters and fats to really be effectively absorbed because THC is fat soluble. And so sometimes if you're eating it on an empty stomach or something else, you might not actually absorb as much THC. So you can kind of have a differential impact with this. Some other less common ways to consume or use THC in cannabis is tinctures and then topicals and patches. So you can have oils, salves, creams, and those are things that you can either put into food underneath your tongue or something that you can be more directed. So a lot of people can use a salve or a patch or a cream because they just want the impact on their shoulder for pain or something like that. Some of those still have that weed smell to them as well. So sometimes not always as popular. And then the last one, just kind of wanted to give a little future and some of the less common products. So suppositories are a kind of an emerging thing with this. Chewing gum is another one, especially with CBD. Mouth sprays, keef, hashish, which sometimes kind of gets lumped with smoking or concentrates. Nano emulsions are also very small kind of concentrates that you use specifically in the mouth. And so I just wanted you to be aware that this is a very, very rapidly evolving field, kind of area of business. And so continues to be a big thing. And so more or less available, but always good to know that there's, if there's a way to consume it, people have thought about trying to use use cannabis in that way. So these are just some pictures of some of the stuff. I just want to point out, these 3, 4 are all different versions of concentrates. And they're just depending on how clear they are, how solid they are, will have different terms associated with it. But honestly, can be really interchangeable the way that they're used. You always have vape pens, usually again has that yellowish kind of tint to it. A blunt with a tobacco paper around that. Those are some of the nano emulsions, so either in a pill form or something like that. And then kind of your classic gummies, I think that we think about a lot with edibles. So when it comes to the pharmacokinetics, so aka how fast it gets absorbed and how our body processes THC and CBD, we don't have a ton of great studies. So but this is one of, I think, the hallmark ones of how we understand how this impacts the body. And so with this, I think this reflects kind of the change that's happened over the past 15 years. Is that back in 2013, they only looked at smoking and oral. And so here you can see that when you smoke something, you have a very, very fast onset of action within 3 to 10, 3 minutes. And so you're starting to get that impact very, very quickly before that, as opposed to oral. So eating or an edible or something like that is going to be up to like 2 to 3, an hour to 2 hours after. So again, the ability to overconsume is much higher with this. And so it continues to be something that we're looking at because there's definitely different things that impact the way that somebody may absorb it. And so this was just a very small study about this. So what is typical use? That's another great question. So when I'm reading a study, it's so difficult to determine what that is and what's problematic and what's not. And so this is kind of a more broad definition that is used in research. So when you're reading something or reading a paper, what do they mean by heavy user? What do they mean by an occasional user, etc. And then also the dose, because it's so different depending on if you're smoking or an edible or a tincture or a salve or something else like that. Can be very, very different. And so this is just one kind of set that's more universal, and I think a more general understanding of what typical use is. And so I just want to show that they use the term cannabis cigarette in this study, actually, so a blunt. So only half would be a low dose, medium is about a blunt, and then high is 2 or more. And I always want to point out too that when we usually are talking about occasional, regular, or heavy use, that occasional is less than once a week. It's just on the blue moon when, like when somebody else is hanging out with their friends. It's not a very common thing. It's like I have a drink when I go out with my friends, or I only drink at the wedding or something like that kind of thing. And a regular user is someone who's using at least once a week, but not every day. And then a heavy user is someone who's using it nearly daily. And I always want to point out that most of the people who are using in this kind of heavy category daily are also using it more than once a day, which is kind of a super level for that. So I feel like we don't always have a great kind of understanding of what is typical usage. And I think typical usage is super up to comparison, depending on who you're talking to. But I wanted to point this out because a lot of times when you read the literature about this, what do they mean when they're saying that? And this is what it is. And so what about cannabis, the industry in Michigan? So we have a wonderful a group that's based off of Laura, and it's called the Cannabis Regulatory Agency that was created when recreational marijuana was legalized. They have all dispensaries have to get a license from the CRA, and then the local municipalities have more authority to either permit or prohibit the businesses. They can limit the number of facilities or the types of facilities, and also enforce zoning. There's also a rule that no cannabis dispensaries can be within 1,000 feet of schools, playgrounds, and other youth centers. Products are heavily tested in Michigan. They have something called a seed to sale tracking system, so they know where the seed was that was planted and grown to grow the cannabis plant, and then all the way over to when it's actually being sold in a store. They are very judicious about looking for contamination with pesticide, mold, fungus, and bacteria. Three of the big ones that are often talked about in cannabis are Aspergillus, Fusarium, and Penicillium, which are very common molds. There's also a rule about the requirement for child-resistant packaging. You also have to label the THC content per serving and per package on everything. And they also have to include a number of mandatory warnings, including that they can only be used by individuals at 21 years and older, keeping you out of reach of children, the Poison Control Center, and also that you're not supposed to be driving motor vehicles while under the influence of cannabis or THC. Now, these are what's on the paper. We're still working on making sure that this happens in actuality. And a lot of things about regulation is how well it gets enforced as well. And still a lot of things that they're working on around this. But I wanted you to know that these are the sorts of things that we do have in writing right now for cannabis retailers in Michigan. So there are certain advertising restrictions as well. So unfortunately, and this is one of my areas of interest, is there's not a lot of gold standards about how you should do advertising when it comes to cannabis. The big thing is that a lot of the terminology is a little bit vague when it comes to this and kind of inherent sometimes when you're doing public policy. So the advertising can't be deceptive or misleading. They can't have any health claims unless they have FDA approval, and there's none currently for THC. And they can't have any images of cannabis plants or products. And so I have this picture here because it clearly has a cannabis plant on it. And so we know that this doesn't always happen. And there can't be pricing, promotional officers, and potency details discussed in the advertisements. And that marketing must not be no more than 30% of the audience is underage. So you're trying not to get it in areas that are going to be close to a school, etc. But when you're driving on a highway, most people are going to be over the age of 21 that are driving. And so you're going to be under kind of that 30% with that. Potency limits. Michigan does have some potency limits. They're mainly around edibles and tinctures. As you can see here, it's 10 and 100. Concentrates, there isn't anything specific in terms of that. They do have a specific thing about Delta 8 that can't be more than 10% of the total THC. They do talk about flower that there isn't a potency limit, but you can only purchase a certain amount. So these are some kind of the limits here in Michigan, which I think reflect kind of the changing environment with this as well. And so there are limits on what can be produced and what can be sold. And so when I'm talking about potency, I think this is a big thing that's come up much more recently as well, is that the potency is really the concentration of the product, of the THC or the CBD in a product. And it's usually, it can be expressed as a percentage, either so it's by weight or in milligrams, depending on what product you're looking at. So often a tincture or a concentrate will express it in a percentage, while a gummy will tell you it in milligrams, which always makes everything very clear. And a big thing, and I think a lot of people know this as well, is that the average THC levels have greatly increased from the early 1990s until now. Usually, and this is all just from the DEA data, and so this is just what was seized by the DEA, and so you can see that this is kind of exponentially increased during this time, from around 4% earlier on to almost 15 to 16%. I will say that in Michigan, we're between 15 to 30%, depending on the product that you're looking at. And I also want to point out that CBD really hasn't changed at all. If anything, it's decreased a little bit in terms of its potency. And so this may kind of reflect our ability to concentrate and process the THC with this. So back to our patient. I know all of that stuff, all of those good things, so then you're aware of. And then so you ask him about all these questions. You want to know what the marijuana he uses. And he gives to tell you about his ratios. And he also says it's totally natural. Love this. Love it. Our bodies make this stuff. And you're like, well, sort of. So THC and CBD are something called a cannabinoid, and they're actually something called a cannabinoid, which means it's a plant cannabinoid. And there's also endocannabinoids, which are ones that our body is made, so an endogenous cannabinoid, and then synthetic cannabinoids, which are delta 8 and different things like that you're thinking of as well. So I won't go too much into this, but and I can never say half the words that are on here because I am not a neurologist or a neuroscientist or anything like that. But I really what I want you to understand is that we do have a system in our body called the endocannabinoid system. It was discovered in actually the 1960s and isn't super well understood, but it's they know it's very critical to modulating. So it's a neuromodulatory network in the central nervous system, and helps a lot with our processes with this. There's tons of different endocannabinoids that are made endogenously in our body. The two main actors that we think about are anandamide and 2-AG. That's what I always just call it. And there's two main receptors that we know about. One is CB1, and the other is CB2. CB1, I think, is the one that everyone always thinks of. Oh, it's just the one that's in the brain, but it's actually very much throughout the entire body. It's in the liver, it's in your adipose or your fat cells, in your skin as well. And CBD2 is primarily an immune cell, so it is found in other areas as well. And there are also a set of enzymes that kind of works in that helps with the synthesis and degradation of this. It is very important, like very early on. It's present at 14 weeks gestation, so really early on. And in certain areas of the brain, it's more active. So with the hippocampus, the basal ganglia, and the cerebellum. And so thought to be kind of why we have some of the effects that we do, because of the impacts of what those functions of that part of the brain does. So a big thing is, and the other thing that I want you to know is that the way the endocannabinoids work is they actually influence the way that other receptors and other neurotransmitters get released. And so they actually have this kind of almost overarching control. So they can control a lot of different things that get released at once. And so they can have this very wide range of impacts, pain sensation, mood, appetite, and memory. And that endocannabinoids actually only bind really quickly to the CB1 and CB2 receptors. Very rapid, and that's just the way that all neurotransmitters typically work. But they bind very tightly. THC, on the other hand, doesn't actually bind super well, but when it binds for a really long time. It's almost like 4 times the amount of time that a normal and endogenous cannabinoid does. Synthetic cannabinoids bind even better, and just for as long as amount of time. And CBD only binds weekly. And so a lot of researchers are kind of under the the thought process that maybe CBD doesn't actually have its impacts through CB1 and CB2. It's actually through a different mechanism. And so a lot of the concern, the thoughts that, oh, CBD isn't psychoactive and different things like that kind of are unfounded, I would say. They definitely works on the brain in some way, shape, or form. Big takeaway here. Endogenous cannabinoids, the ones that our body makes, are exceptionally short in their duration of action. They're on and they're off. Exogenous, aka phyto or synthetic cannabinoids, act much longer in a non-physiologic, aka non-natural way that they activate the receptors. So they do work on a pathway that's already there that we use, but not in the way that our body initially intended it. And so that's a big thing I usually talk to people about because nicotine, alcohol, they all work on receptors that we have in our body. And so, quote unquote, can be natural, but don't necessarily work in the way the body intended. And so that's why you get some of those negative impacts. So kind of back to our patient, he said, well, forget it. Forget what you said. I heard there's actually pill forms that you can prescribe. Can you just prescribe me it then? Because those must be safer, right? So again, not wrong. So here in Michigan, we do have medical marijuana. And so patients must have a qualifying medical condition by law or either petition. And so I didn't list all of them here. It is a very, very long list of what a qualifying medical condition is. And so cancer, HIV/AIDS, IBD, autism, cerebral palsy, chronic pain, seizures. Those are big ones I think that come up. A Michigan licensed physician completes a written certification for the patient, though you don't prescribe marijuana to someone. Instead, you certify that the patient may benefit from the use. And then the patient then goes and submits the certification application to Michigan Medical Marijuana Program and gets a registry card, like you can see on the right here. You're actually allowed to do this at 18 years of age, and you can below the age of 18, but you need parental consent and you need 2 physicians to sign off on this. In addition to being able to purchase those products, you also can cultivate 12 plants, and there's some products, particularly high CBD, that's only available if you have a medical card. There's also some exemption with excise tax, so it makes it a little bit more, it's a little bit cheaper with that. So some of the FDA approved medications or pharmaceutical kind of company medications that have this are here. And so I did include the brand names here just because I think a lot of people use them. I'm not supporting any of these companies or anything like that. I just wanted you to be aware because a lot of times we will use these terms with that. So dronabinol has been around for quite some time. I think that's the classic one that we think of, and it was first approved in the 1980s. And it's primarily used for chemotherapy-induced nausea and vomiting. And that's really been where it's been found to be really effective. And so again, that's FDA approved for that. And so that's usually, it's a synthetic THC that's usually given in a capsule or an oral solution. Nabilone is kind of similar to that. It's a synthetic THC as well, analog. So it's not exactly THC, it's just a very similar looking thing. It was also approved in the 1980s and does something quite similar with nausea and vomiting. Nexibismol is not FDA approved, but is approved in 25 other countries, including the UK, Canada, and Germany and Australia. So it's something that's been kind of discussed for a lot of time. This is a whole plant extract, so it's not synthetic, and it has a kind of combination of THC and CBD, and is used specifically, usually in muscle spasticity and multiple sclerosis. So it's been very narrowly kind of studied for that. It's also used off-label in some of these countries for cancer pain, neuropathic pain, and palliative care. Another one that we talk, I think, a lot about is cannabidiol, which is a plant-based CBD. So all the other ones either had some form of THC in them. And this has been approved in the United States since 2018 and was descheduled actually shortly after that, and has continued to kind of add diagnoses to what it's FDA approved for. So typically there are very severe seizure syndromes such as Lennox-Gastaut, Dravet, and tuberous sclerosis. It can be used off-label for certain refractory seizures as well. So this is a big one I think that people talk a lot about and is the one that continues to kind of be touted as a big reason that we need to keep looking into THC and CBD as for their positive impacts. So getting back to our patients, obviously we can't probably prescribe any of those because it doesn't really have any of those reasons. Um, but you start asking him about his marijuana, and he says, "Oh, I use it, when I wake up, before I go to sleep, when I go driving, when I go skiing. But don't worry, I have a really high tolerance." And so I'm sure that you've all had this where someone's like, "Yeah, I use it however many times a day," and you're like, "Oh no!" So now you're starting to put your harm reduction lens on, your and hat on. And so I always want to, I always ask the patients, you know, you can get a DUI. Can you get a DUI? Do you know what the open container laws here are in Michigan? So I'm sure that it is illegal to drive under the influence when you are impaired by cannabis, either medical or recreational. I think that's really important too to note that even if you're using it for a medical thing and you're under the influence, you can't drive. There isn't any legal THC limit or per se, and the impairment is really determined by the officer, and so officer observation. And so usually what you'll get is if you're caught doing this, you'll get an operating while intoxicated, and so it's based on kind of field sobriety tests. And I want to point out that in the legislature it says blood THC testing. We'll talk about this in a second, but not super effective. A first-time offense can be quite significant. It's a $500 fee, 93 days in jail, community service, and your license being suspended as well. I also want to point out open container laws. So cannabis, you can't just have it in the seat next to you. You have to have it in a sealed and labeled container. And usually it's recommended that you store it in the trunk or an area that's inaccessible to the driver. And that even an open container, even unused in the passenger area, can lead to penalties with this. So I always want to point out as a pediatrician that oftentimes we also put children in the backseat where we put our cannabis, so it can be kind of an issue with this. So really important thing that I talk to about with parents, where they're keeping their cannabis, if it needs to be in the trunk, etc. With this, just be mindful that we don't want kids getting into it if you're putting it in the backseat, inaccessible to you, but very accessible to them. So monitoring and lab testing. Very difficult topic, and kind of unfortunately not as easy as a lot of the other drug testing that we think of. The classic one that I think that everyone knows about is the urine drug testing. That looks at THC carboxylic acid levels, so not THC itself. The detection window is all over the place. So one of the biggest things, and I want you to take away from here too, is that chronic users can actually be positive for 2 months after. This is a huge thing that comes in, that somebody will come into the emergency department and they will say, I haven't been using, but then their THC comes back positive on a urine drug screen and they say they're lying to me. And so the big thing is that this can be positive much longer than if they had just quit 2 weeks ago. So really important to know. And that naive users may not be positive. So that's a big thing. So if a kid has consumed something and comes in and appears to be under the influence and they don't test positive, it might just be because of that. And it can take a while to reach detectable levels. So you might have kind of a window in there. Another one that comes up is the blood testing, and that looks specifically for THC levels. That's a very difficult send-out test to do, and it peaks very quickly after use. So you have to kind of get it really kind of tightly right after use. It can be elevated in chronic users. It's actually because of the way that the THC is kind of held usually in fat cells and then released slowly over time, but just not as commonly used and not always as easy to not as commonly used. And then this is also my other thing. I don't get what the big deal is. Isn't it supposed to be really safe? And so I know I got like 12 minutes left, so I'll kind of talk about some of the big highlights here. And so one of the biggest things that I wanted to point out too is that the National Academies came out with these 2 amazing study reports. One, the health effects of cannabis and cannabinoids, which is a lot of what our understanding about the long-term health impacts of cannabinoids are. It's a wonderful, wonderful report that really is nuanced and goes through this. It was back in 2017. I'm praying that they're going to do another one because now it's been almost 8 years since they've updated this. Most recently last year, they talked about cannabis policy and impacts about public health and health equity, which I think is super important as these policies change. A more recent one that kind of talked about kind of a broad range of health impacts. This is one in the British Medical Journal in 2023. And also this other one I wanted to point out here, which is a really great toolkit for having conversations with a harm reduction lens as these kind of change. So I wanted to point out these resources before I start talking a little bit about this, because I always know that I'm going to have to talk too fast through it. So short-term effects, I think we classically know about all of these. One of the big ones that I want to point out is that rapid heartbeat is the big thing that some people get a lot of palpitations with that. And it slows your reaction time, your impairs balance and coordination, your cognition, you get the munchies, all classic stuff with that. Some of the long-term effects, I think the one that we forget about the most is cannabis use disorder. So if you use cannabis long-term, you're much more likely to have a use disorder associated with it. And the risk increases with how early and how frequent your use is. So cannabis use disorder, it's around 10% of the population right now. And maybe it's a little bit lower, maybe it's a little bit higher. Again, I think as more time passes, we'll have a better understanding of that. Withdrawal is also very common. If you stop using after using for a long time, it's a very common thing to happen. And then cannabinoid hyperemesis syndrome is a huge thing. So this graph on the right shows post the changes in the cannabinoid hyperemesis emergency department visits over the years, and as you can see, has greatly increased. From 2014 onto that. There's some concerns specifically around head and neck and throat cancers, a lot as associated with smoking, so makes sense because it's a lot of exposure there, as well as some testicular tumors. There's a lot of concerns about the cardiovascular risk, and this is kind of all over the place, unfortunately, sometimes with the data. There's a lot of times because it does impact the heart rate and different things like that, that you can have abnormal rhythms, and it's actually thought that this is why it might cause a heart attack and a stroke, as opposed to actually kind of contributing to the plaque formation. There was a very good study that came out recently that associated smoking cannabis with the development of COPD. Obviously, if you're smoking something, you're going to have some respiratory impacts with that. There's some more kind of emerging evidence around metabolic and gastrointestinal concerns, links to prediabetes, visceral fat, altered insulin sensitivity. Again, THC is fat soluble and often works kind of in tandem with that. And then some concerns about peptic ulcer disease, GERD, and pancreatitis. And this may be more due to the nausea kind of impact with cannabinoid hyperemesis. A lot of the stuff is kind of all over the place, but I just wanted to highlight these as kind of the most prevalent things that we've noted in the data so far. I wanted to have this here for you too. So the DSM-5 does have criteria for cannabis use disorder with a mild, moderate, and severe kind of differences. So the severity of the cannabis use disorder. And so very classic kind of typical things that we think about with a substance use disorder, such as using for long periods of time, not being able to cut down, negative health impacts, etc. And withdrawal is a big one with this too. As someone who sees kids, I always want to point out that a lot of times there's been concerns that have been recently raised that adolescents might not meet the criteria for cannabis use disorder, but still have problematic usage, which is kind of a conundrum to me sometimes. So there was this study that they recently did that they showed that adolescents who use cannabis in they call it non-disorder cannabis usage, as opposed to cannabis use disorder, had increased levels of mental health disorders, negative impacts on cognition, academic performance, and delinquency, much more in comparison to their non-user peers, but less so than their cannabis use disorder. And so that was a big kind of thing that kind of highlighted that even if someone doesn't have a cannabis use disorder, it doesn't necessarily mean that their cannabis use is not negatively impacting them. And maybe this kind of reflects the fact that we have the definition currently just doesn't quite capture what might be problematic in adolescence. So cannabis withdrawal syndrome. So I want to talk about this because this definitely is something that happens typically is within a day or two of quitting. It usually can last 2 to 3 weeks. So it's really important when you're talking to somebody about quitting to let them know that this is going to happen. You can have physical symptoms in addition to cravings, headaches, abdominal pain. Usually people don't want to eat. You can get sweating and chills, and just a lot of just not feeling great, difficulty concentrating, not feeling anxious, depressed. Kind of I always talk about like the reverse of what you feel when you're high can be a lot of this as well. So important to tell people that this is going to happen and can get through it. So mental health, I know that there's a talk about this. I won't spend too much time about this. It's a very chicken and egg, what direction is going on around this too. And so with psychosis and schizophrenia, kind of our current understanding is that cannabis may initiate emergence of an underlying psychotic disorder with those with a genetic predisposition, but not necessarily cause it, if that makes sense. There's also a lot of concerns around increase, especially in adolescence. That's actually where we have the most data around mental health disorders such as major depression, suicidality, mania and hypomania, anxiety, social anxiety, and there's some concerns about the increased risk of other substance use disorders, including nicotine and alcohol, but it's very difficult with the directionality there. Another thing that I want to just point out is that they have, and this is a big thing I talk to my adolescents when I'm talking to them about, is that it's been very well shown, demonstrated that adolescents who use cannabis frequently can have more negative impacts on their cognition, and they're not sure if those brain changes that they actually see on imaging and in testing, actual testing, will improve after abstinence. And so this they've shown in adults that if you had started smoking or using cannabis in adulthood and then stopped for a period, your brain would actually go back to normal, and so would kind of your functioning, your cognitive functioning. But with adolescents, they haven't been able to they've shown sometimes that actually that's kind of a sustained change from that. And so it's a big thing I talk to my youth about, is that if you're going to use, can you please wait until you're 21 so your brain's done developing, because some of these impacts might be permanent. And they're kind of just like across the board when it comes to these negative impacts. And these have all been adjusted too for sociodemographics factors. So like parental support, parental education, their location, urban, rural, those sorts of other things. So I think that's really important too. There's some concerns about motivation. And so again, this is just a really funny article. So yeah, whatever, a rat, that they did with rats. And so kind of that they were just not as willing to exert cognitive effort. So obviously has not been shown in humans specifically, but I just thought it was funny. I think you have a talk about pregnancy, so I won't go too much into this, but really important. Cannabinoids do cross the placenta, and they are in breast milk. And so it's a thing that I have to talk to my parents about a lot, because we don't have a ton of great research on what exactly this does and what exactly the negative impacts are. And it's kind of a concerning and continue to be a thing that we're monitoring. But Doc, can't it just help with my symptoms? Won't it just make the meds work better? Big thing that comes up. This is what I use as my therapy. So cannabis has been shown to be effective in a couple of different things. So chronic pain, neuropathic pain. We know that there's a couple medications that are approved for chemotherapy-induced nausea and vomiting. It's approved for appetite stimulation, specifically in HIV and AIDS and cancer. We know that it can be helpful with spasticity and pain and multiple sclerosis. There's some weird evidence around short-term sleep outcomes. So if you have, say you have multiple sclerosis and you can't sleep because of the pain, spasticity, and you take cannabis to help you sleep, it can be helpful with that. And then of course, specific epilepsy syndrome kind of associated with that CBD. There's very weak evidence around this, and this is the ones that actually had evidence one way or another. So this is just not like, oh, these are all the list of things, but they actually looked at this to see if cannabis would be helpful, and it wasn't shown to be helpful. So glaucoma was a big one that actually used to be a huge treatment that's not effective. IBS is another one. Anxiety disorders, PTSD, sleep disorders, so like more generally, just general insomnia. ALS has been a big area of study, as well as other dementia and Parkinson's, schizophrenia and psychosis, which makes sense that given that it might worsen that. Anorexia, given the appetite suppression, appetite stimulation. Cancer therapy, so has been looked at to see if that would be effective. And addiction of other substances. So again, there's been quite a few studies that have looked at what other ways that we could use cannabis and haven't found really weak evidence or no evidence around this. One of the other things I always want to point out, and I this is more of like a list for you as opposed to something I'm going to go through specifically, is that I want people to talk to me about if they're using cannabis, because it does impact other medications. It impacts cytochrome P450, and so can impact the way that your body metabolizes estrogen. So contraception is a big thing, blood thinners, Tylenol, and other antifungals and different things like that. And can be synergistic with alcohol and other CNS suppressants. So really important for them to share, because this is something that I need to maybe change a dose, or maybe not prescribe a certain medication if you are using cannabis. So yeah. So back to our patient one last time. So after your conversation, the patient admits he didn't know he was actually using too much, and his motivation was really affecting his motivation and his mood. And he agrees it's a daily habit. Maybe he wants to cut back, maybe even quit. You're like, yes, score. So the treatment of CUD. Unfortunately, this is a very short section because there's not a lot going on. So behavioral and psychosocial approaches is the one that they have the most evidence for. There's a variety of different therapies that have been looked at. Cognitive behavioral therapy is kind of the one that's been leading the way, especially if you have family involvement. There's currently no FDA-approved medications with this. There is some evidence for N-acetylcysteine only in adolescents very randomly, but that can help with kind of just the withdrawal symptoms with this. There's been some other things that people are still looking at, including gabapentin, topiramate, and dronabinol, some limited evidence, and some more big studies that are coming up. Another thing I always want to point out is that sometimes this is not going to be something that someone quits just cold turkey. It's going to be something that maybe first we consider cutting back, so delaying first use, reducing the number of days a week, decreasing the potency of the products, and then or just simply using it more safely. So avoiding high-risk situations such as driving with others, synthetic cannabinoids, and unregulated products, or not mixing with others. And then encouraging especially our adolescents to have open conversations with parents and others to support them with this. So big takeaways. So that was a whirlwind. But again, so then you can have all of this for you, is that cannabis is not benign, especially for youth. It's really important that you're talking to them, asking early, asking often, and being very open about this. Staying engaged and in research. It's constantly evolving. I think I've done this, updated this presentation like every 6 months, like I said. And then meeting particularly youth and others who are using it where they're at and offering support. Maybe they're not ready to quit, but they might be ready to use more safely or use in a different way. So I always love, after my whirlwind, to have this nice peaceful video of cannabis blowing in the breeze, just to kind of take our own deep breath after all of that information and start to just stay in there. So, but thank you. And so I will take questions now. So I think I saw some pop up too, so I will stop sharing my screen too, so that way we can share the other slides so you guys can all get credits for listening to me for a whole hour.
Thank you so much, Dr. Taylor, for that wonderful presentation. As she said, we're not going to open it up for questions. We do ask that all questions be submitted through the Q&A function, which can be found at the bottom of your screen. And then as a reminder, this webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. But on to questions. First one says, my clientele seems to deal with alcohol, crack, meth, and fentanyl addictions, and they feel that cannabis is the least or healthiest of any of these substances to get addicted to. How do we convince them of the dangers of cannabis?
I think that's a really hard discussion to have. And I think this happens a lot with nicotine too. So those are the two things I think I talk about the most. And so a lot of times, it's that harm reduction approach with it too, that any substance can be harmful with that, and maybe cutting down or not co-using with other substances. It's a big thing that if you're doing if you're trying to have someone get to cessation, for some people, it's actually more effective to have cessation at all the same time for these things. But a lot of times that's such a huge, major life change that one at a time in a kind of stepwise fashion is easier. I think some of the more long-term impacts on heart, lungs can be really, really important. And then the cognitive impacts is another thing for a lot of folks as well. That can be really a big driver to help cut down. But I agree that with polysubstance use, it can be so difficult to have someone cut down on cannabis when they're using other substances.
Thank you. And then earlier you were talking about the typical use standards. Someone asked who defined these standards.
So that was based on a definition that was in that study, and that's often what is quoted in other studies as typical use patterns. And I put that in there not because I think that that was what typical use is and that's a stagnant definition, but a lot of times when you're reading other literature, that is the study that they cite. And again, that was from 2013. So I think that that probably has changed. I mean, we already know the potency has changed quite a bit during that time. So I put that up there because it is such a nebulous definition with that. And so I think it's super important to know that and know that that might not actually reflect what typical use actually is. So.
Kind of on that same topic, someone asked, like for someone who, like if we're defining this, like have use as someone who uses daily, would you still use that same terminology for someone who's using smaller doses, such as like below 7 milligrams daily?
So typically anyone who's using daily is that because of the kind of the half-life that's typically with it, it's still kind of in the system with that.
You mentioned some places in which it is or isn't legal to use. Do you know if it's illegal to use in public parks?
It depends on the public park and the municipality. So some parks it is allowed. It depends. So smoke-free parks are not something that's necessarily across the board. And so their definition of smoke is also different. So it's not illegal to smoke cigarettes in some parks. So it's also not illegal to smoke cannabis in some parks. It depends. It just specifically depends on where you are. And so there isn't a specific definition. I know that in state parks it's illegal to do that, but that's not necessarily in your city park.
I see. And then our speaker yesterday noted that the THC content in gummies is not always reliable and dismissed the idea that folks can moderate use. And they're wondering what your thoughts are on that.
So this is a very hotly debated topic as well. So I think it depends on where you are. I honestly, I swear the cannabis CRA doesn't pay me, but they they're really tightly regulated in terms of that. And so obviously they don't test every single gummy or every single batch. It's like they take one sample and they say, oh, that's about what it is. And so it just depends on the quality of it. I think we do a pretty good job here actually monitoring that and making sure it's about the same amount of use. That being said, I think a lot of people will cut a gummy in half or a quarter or something like that, and you don't know exactly where the THC or CBD component is in the gummy. So if you cut the gummy in half, your THC, you could get like no THC and all of it's in the other half. So I think that's a big thing that often comes up. Or if you're making your own gummies, you have no idea in that entire batch where that is. So that I definitely gummies can be a difficult thing, but generally speaking, we do a better job. Some states do not have the same levels that we do in terms of monitoring. So.
This one's a bit of a broader question. It says, in general, what are physicians' attitudes regarding treating patients that are using cannabis?
So I think that's a really great question too. So there's a lot of studies that they've actually kind of done to look at providers, medical providers too. I know physicians are not the only people who take care of people about what their impressions are and their ideas around cannabis, and that has greatly changed in the past 10 years. And so there was a lot of there's a study in, I think in 2012 that they did in Colorado, right before the legalization, and people were pretty negative about it. And that's changed quite a bit over this time period. And so kind of mirroring what we as a society would say is our expectations and acceptability of cannabis use. I don't think that most medical providers are sure what to do for it. And so that's why they might not be addressing it. As I got to the end of the presentation, it's not quick because I was even hurrying. There just isn't really a lot about cannabis use disorder and treatment or help with withdrawing in a comparison to what we have for tobacco, alcohol, and opioid use disorder, which we still don't have a ton for all of those things, but we have more than nothing. So.
Thank you. And then we have time for one more question. This person asked, what safety planning steps or ideas would you recommend for parents who use THC products while caring for their children?
That is a great question. And so that is a big thing that I talk to my adolescents about. I mean, not my parents who might be adolescents. I suppose it's not exactly different, but especially with our new moms and dads who may have been abstinent for a while during the pregnancy or something like that. that making a safety plan about who's going to watch the kid, and kind of if you're going to have a night out, and like if something were to happen where you weren't able to pick up the baby, or an emergency happened, what would you do? And so that's important to know. So the same way that especially if someone's had a baby, and they go to have their first glass of wine or something after, they know that they're going to be a cheap date. And so being aware that the way that your tolerance has definitely changed over this period, and so that's a big thing. And so any can be a lot, and so just making sure that you're aware and kind of have a plan for this. And if you're going to use, especially to go to sleep or to have a very sustained psychoactive effect, that you have someone else that's watching your kids. I know that's not always possible, but it's important to talk about with parents, particularly who are using.
All right, thank you so much. That was our last question. And just to go over a few closing remarks. First of all, thank you all for attending today's webinar. We hope you found it both informative and interesting. We would greatly appreciate your feedback so that we can continue to improve our future webinar offerings. So please use the link in the chat or the QR code on the slide if you haven't already done so to complete that feedback survey. As a reminder, this webinar has been approved for 1 social work credit, 1 back credit, 1 MISHWA credit, 1 CHES credit, and 1 CME credit. So if you're requesting any of those credits, you must fill out this form with your name and email address. We'll also be sending this form out to all webinar attendees this afternoon. And for our next presentation in our series, Dr. Leslie Lindahl will be presenting adolescent cannabis use tomorrow at noon. And if you have not yet registered for that or other sessions in the series, please use the link in the chat to do so, or visit washtenaw.org/marijuana. We hope to see you at the next webinar, and thank you all for your participation. I'll hang out here for a few more minutes in case folks still want to use the link in the chat or the QR code on the slide. But otherwise, thank you, and we'll hopefully see you tomorrow. You're getting a lot of thank yous, Dr. Tayler, for the presentation.